morning, everybody. I'm Marta Kalužna-Oleksy, interventional cardiologist from Poland. Okay, so I will start again. Hello, everybody. Good morning. I'm Marta Kalužna-Oleksy from Poland. I'm interventional cardiologist, and it's a great pleasure to co-chair this session today with Dr. Mamas from UK. And we will have very nice and very interesting key lectures in this session about bioelectronic treatment and about a career journey. So stay with us, and if you have questions, please feel free to ask.
So it's my pleasure to introduce the first speaker, Dr. Stavros Zanos. Dr. Zanos and I follow each other on Twitter, although I don't think we've actually ever met in person. He works in the Feinstein School of Medicine. He does some great research, both translational and clinical, in neuromodulation of cardiovascular disease. So over to you, Dr. Zanos, around bioelectronic treatment of chronic inflammation.
So I guess it will be in Greek or in English. English, excellent. That's much easier for me, I have to say. I've lived in the US for almost 20 years, and even though I was originally born and raised in Greece, my scientific knowledge of the Greek language and the English language are not comparable. So in Greek, this is in Greek, the title, and in English it means bioelectronic treatment of chronic inflammation in cardiovascular disease and the role of sex or gender. So like Dr. Mama said, I'm at Feinstein Institute for Medical Research, and I'm an associate professor at the Zagreb School of Medicine, both of which are part of Northwell Health, which is a very big health system in New York, the biggest in New York. Actually, I think they're the biggest employer in New York as well, of over 100,000 people. The Research Institute is part of the North Shore Hospital, which is probably the biggest hospital in Long Island, and it's that building there. And within that institute, I had a lab. My lab sits at the intersection of three main areas. One is neuroimmune dysfunction in cardiovascular disease. You will hear a lot of terms that you might not be very familiar with today, so I'll explain a lot of things. Cardiovascular disease, there is immune dysfunction, and in the last, I'm going to say 5 to 10 years, a new theme is emerging where the nervous system and the immune system are talking to each other, and there is dysfunction in that crosstalk. So we're very interested in that. We learn about that by studying the biology of neuroimmune interactions, and we do that both in patients and in experimental models. And all of this knowledge of the biology of interactions, along with the dysfunction of these interactions in cardiovascular disease, we're trying to treat with neuromodulation, which is a method of neurostimulation. We stimulate the nervous system to change this crosstalk, this altered dysfunctional crosstalk, with a specific focus, again, on cardiovascular disease. It's an emerging area of translational medicine, but I think there are some early signs that it might be clinically very relevant. And it's the health footprint of these treatments is, I would argue, very significant because of this condition, because of chronic inflammation. We heard about it in previous talks. Chronic inflammation appears in people who are generally overweight, even though that's not the only scenario. And an overweight or obese individual doesn't just have an increased BMI. There is a whole range of symptoms and signs and syndromes that are affected, including the lung, the heart, the liver, of course, the visceral adiposity, the kidney, and the skeletal muscle. So this chronically increased inflammatory state has been implicated in a very wide variety of diseases, including cancer. These are things that we're learning the last maybe 10, 15 years. Of course, obesity, diabetes, neurodegenerative diseases, interestingly, both Alzheimer and Parkinson's disease, autoimmune diseases like rheumatoid arthritis, and of increased interest to people here in this conference, cardiovascular diseases. And all of this discussion of chronic inflammation in all of these different diseases has something in common. And there must be a reason why chronic inflammation is implicated in cancer and in metabolic disorders and cardiovascular disease. And the reason is because inflammation is controlled by the nervous system. It's not 100% control. The nervous system doesn't magically turn it on and off, but it tightly regulates it. And this is because there is a connection between the brain and the spleen. And I'm oversimplifying it a little bit, but you've all heard of the vagus nerve. It's an important cranial nerve, the longest and the most complex cranial nerve. And as you can see, the descending fibers of the vagus nerve make a synapse at the celiac ganglion, which is inside our abdomen, right next to the aorta. And from the celiac ganglion, these neurons, these ganglionic neurons in the celiac ganglion project to different organs, the kidneys, the gut, but also the spleen, the pancreas. Now, the spleen is an interesting organ. When I was in medical school, I remember the only reason we would mention the spleen is because somebody got injured and the surgeon had to remove the spleen, splenectomy. That was pretty much my knowledge of the spleen. Ever since I moved to New York, to Feinstein, I learned that the spleen is actually a pretty important organ. One, because it controls immunity to a large extent, systemic inflammation, the immune response, antibody production, deployment of macrophages and monocytes to areas of infection. But also because of this splenic nerve, there is a very tight control of all these immune processes by the nervous system. So the idea is that these ganglionic neurons in the celiac ganglion release neurotransmitters. In this case, it's norepinephrine. Those neurotransmitters bind to receptors on T cells, on T lymphocytes, on specific receptors, adrenergic receptors, and those T cells, that special type of T cell, releases a different kind of neurotransmitter called acetylcholine. And that neurotransmitter, by binding to cholinergic receptors on macrophages, changes their phenotype, changes their behavior. So if a macrophage is a little angry and it's willing to translocate to a different organ and fight inflammation, or maybe cause, in a chronic state, chronic inflammation, the release of these neurotransmitters kind of calms it down, right? So you can imagine then if we could somehow activate some of these nerves, the vagus nerve or the splenic nerve, with devices, not drugs, we could have this interesting and very beneficial effect on the immune system. And that's the basis of what we call bioelectronic treatment of inflammation. And people have tried it at different levels. This slide I used to have in English, and I thought the talk would be in Greek, so I changed some of the terms. But really what it means is it's the different areas of the nervous system at which we can stimulate to activate this reflex, this neural pathway, and suppress inflammation. And this is important because some of them are invasive, so we need a surgical operation. Some of them are non-invasive, so pretty much anybody can do it. The standard way of activating the circuit is with the implantable electrode in the cervical vagus nerve in the neck. And this has been used for decades in epilepsy and recently in rheumatoid arthritis, as we will talk about. But there are additional ways of doing that. You can stimulate the cutaneous branch, the auricular branch of the vagus nerve with a transcutaneous device, like a TENS device that you can buy from Amazon, really. Or you can use ultrasound to stimulate the spleen itself, or the splenic nerve. And these are areas where we do a lot of research in New York. So I'll talk a little bit about those. So let's talk about the main way of activating this pathway, the cervical vagus nerve. This is a study that was announced a few months ago at the American College of Rheumatology. really the first multi-center placebo-controlled or sham-controlled study of VNS, of vagus nerve stimulation, and rheumatoid arthritis, the RESET-RA trial. As you can see, the two groups, the red group and the blue, the red group is the one that received stimulation. The blue is the one that received the sham. Initially they start about together. On the y-axis is disease activity. It's one of those metrics that the rheumatologists use to understand how active the disease is. And you see that they start at the same level, and then as the time goes by, weeks, not months, I guess the red trace becomes higher than the blue, meaning that there are more responders in the stimulated group than the sham group. And then when they switched, when those that were being stimulated switched to sham and vice versa, those trends were reversed. So that's very clear evidence that this treatment worked. And it worked for that score, the percent of responders based on the ACR score, but also based on the DAS28. These are all different scores that the rheumatologists use. As you can see, there is clear difference between the blue and the red bars, which increases as time goes by. And you can see that after 12 weeks, there is a significant difference in the rate of responders between the two arms of the study. And then when they switch, those differences disappear. So this is very exciting because it will most likely lead to an FDA approval of this device. And this is a company called SetPoint that started at the institute I work at. So we're very happy about that. And also, it demonstrates in principle that this treatment works in chronic inflammatory conditions. And now we're looking into applying this treatment in many, many diseases, from cancer to obesity to cardiovascular disease. There is another way of stimulating the same pathway by placing an electrode on the ear and stimulating at this low current. You can see that it's like a clip, and you can use any type of clip for that. You can buy it on Amazon. It doesn't require any special prescription. One of the first studies that looked at the therapeutic possibilities of this approach was one by Stavros Stavrakis, with whom we're working together. It was in 2020 in the treatment of atrial fibrillation, the TREAT-AF trial. You see that after 6 months of this non-invasive 5 minutes a day treatment, the percent of AF burden was significantly reduced in the people who received active stimulation versus those that received sham. So that's a reduction of about 20%. More recently, a few years ago, one of the PhD students who is Greek in my lab, Stefanos Zafiropoulos, summarized the results of several randomized controlled trials of different approaches of neuromodulation in the incidence of post-operative atrial fibrillation. And he found that actually the effect is quite significant. The hazard ratio of treatment versus non-treatment was about 0.37. This is highly significant effect, and it actually, this particular study, it was the first meta-analysis of all of these treatments in cardiology, created a lot of interest among cardiologists in the US and in Europe. We still receive emails about this paper. And a few, I would say, weeks ago, we published this study in JACC-EP, where we tried the same approach, so transauricular nerve stimulation, in ventricular arrhythmias, not just atrial. Again, this showed about a 14% reduction, which is, I'm going to say, highly significant for an intervention that is very cheap and completely non-invasive. Also, this effect happened after only 10 days of treatment. And one thing that people in neuromodulation, mostly anesthesiologists and neurologists and neurosurgeons see is that over a period of several months, the effect of neuromodulation is additive. So you see some effect at 1 month, 2 months, at 12 months is even more significant, and after 2 years it's even more significant. So this was a very early trial. Now we're running a longer trial to see if after 6 months of treatment, the results will be even more important. There is one type of neuromodulation that we particularly study in the lab. It's called ultrasound of the spleen. And the reason we use ultrasound is it's a mechanical vibration. If you switch to the correct frequency and intensity, you basically bring biological tissue in this type of oscillation. If that biological tissue is a nerve, it's almost like stimulating with electricity, but you don't use electricity. Now, the big advantage of ultrasound is that you can use it for imaging, so you can use it to visualize the target, if it's the spleen or the liver. And then it's completely non-invasive and very safe. So what happened when we did that? This is basically a standard probe. The system we used in these studies was developed by GE, General Electric Healthcare now. Back then it was General Research, Global Research. Now they merged with GE Healthcare, and we've been working with them for, I'm going to say, 6 years now. And the idea is that if you administer this treatment, this mechanical energy to the spleen, it activates the splenic nerve. The splenic nerve releases norepinephrine, neurotransmitters, and you suppress inflammation by doing so. So one of the first studies back in 2019 that we showed that you can see on the left that the amount of neurotransmitters in the spleen increases from zero energy, which is on the left, the bar on the left, to a higher level of higher energy in the middle in a dose-dependent way. And not only the neurotransmitters are released by ultrasound, but those inflammatory cytokines produced in the spleen are reduced as a result of that. And that's what you see on the right. The left side is the degree of inflammatory cytokines with zero energy, and in the middle with higher energy. You see there is dose dependency in that as well. So not only neurotransmitters are released, but the release of those neurotransmitters in response to ultrasound reduces inflammatory cytokines. A different group from Minnesota is a good friend of mine who is developing an ultrasound system for home use for neuromodulation, looked at the effect of ultrasound in a model, in an animal model of rheumatoid arthritis. And as you can see, the red is the sham, the purple curve is the active stimulation. They start together, but they eventually deviate over pretty much a period of a week. So it's a very robust and fast effect suppression of inflammation in the model of rheumatoid arthritis. I'm going to talk about the recent work we've been doing in the cardiovascular space and using this treatment to address pulmonary hypertension, pulmonary arterial hypertension, so type 1 pulmonary hypertension. And the model, I don't have to tell you much about the disease, how devastating it is, and the fact that there are not a lot of disease-modifying options out there. We basically focus on alleviating vasoconstriction in the lungs, and that's about it. But we think that these approaches might actually modify the natural course of the disease. So the way we develop pulmonary hypertension in these experimental animals is by placing the rats inside the chamber, reducing the oxygen, something like 10%, and then injecting a particular chemical. So that causes vasoconstriction in the lungs. And also this chemical causes an angiogenesis response. Together, over a couple of weeks, these animals develop pulmonary hypertension. So we can then test our treatments on these animals. But the first thing that we wanted to know is whether these animals have inflammation at all, because we're talking about an anti-inflammatory treatment, right? So this is work that another Greek PhD student is doing in my lab, Alexandra Bekiaridou. This is unpublished data. She's writing the paper now. She found that a variety of immune cells are altered in the lungs of these animals with pulmonary hypertension. And these are, for example, on the top left, you see the blue is healthy animals. The red dots are animals with the disease. And those are pro-inflammatory macrophages in the lungs. And the way she can measure all of these cells is by flow cytometry. So she takes the lungs, places them in the flow cytometry machine, and reads the counts. So higher counts of inflammatory cells in the lungs, as well as other immune cells that are changed. So there is some kind of inflammatory response, chronic inflammatory condition in the lungs of these animals. Also, interestingly, she looked at the spleen of these animals and she found similar trends. So not only the lungs are affected by inflammation, but the spleen of these animals is also different. So there are more pro-inflammatory cells in the spleen. It kind of looks like the spleen is taking part in this chronic inflammatory condition. So we wanted to know more about it, and that's why we did splenectomy. So we removed the spleen from these animals, and we found that actually the removal of the spleen made the disease worse. As you can see, the blue and the red, these are healthy animals, and the green is the animals that did not have splenectomy but developed the disease. Purple animals are the ones that had the disease after they performed splenectomy on them. So the disease is worse in those animals with splenectomy. Is it the spleen, removing the spleen, that is the reason for this worsening? Or is it the nerve? Because of this splenic innervation we talked about. For that reason, we actually removed the nerve of the spleen. So we kept the spleen, but removed the nerve to see if anything changes. And interestingly, it does change. When you remove the nerve, the disease gets worse. Again, that's the purple dots there. So to us, this all said that, okay, the nerve of the spleen, this inflammatory reflex, may have a role in pulmonary hypertension. So what about if we stimulate that nerve? Would that treat the disease? And we stimulated that nerve with ultrasound. And this is the paper that came out last year. And actually, a couple of friends wrote a really good editorial in Circulation Research. And the figure I have here is from their editorial, not from our paper, because they did such a good job summarizing the paper. So these animals received ultrasound of the spleen after we induced the disease. So these were subjects with the disease. And we found that the right ventricular systolic pressure, the right atrial pressure, the workload of the right ventricle, and the hypertrophy of the right ventricle were all improved in the animals that received the treatment. And I'm going to say that it was very robust and consistent finding over multiple cohorts of animals. It's unlike in translational science, in experimental science, you have a lot of variability. I mean, even the day of the week that you do some experiments plays a role in the results. This was a very robust, very repeatable finding. Very impressive, I'm going to say. It affected the BNP levels. It affected cytokine levels in the spleens and bloods of these animals. When we removed the splenic nerve in these animals and still gave that treatment, the effect went away. So you really need the nerve to be engaged by this mechanical energy to have this effect. Stefanos Zafiropoulos, who was the first author in this paper, looked at the lungs of these animals and did the single-cell RNA sequencing to understand what molecular pathways are affected by this. And he found that it was mostly inflammatory markers, TNF-A signaling, on monocytes, macrophages, and in a different kind of interstitial and alveolar macrophages. So it's the innate immunity that is affected in the disease, and that it's partially normalized in animals that receive the treatment. And many of these genes that are affected by treatment in the experimental animals are also very relevant in human disease. So he has a really nice analysis of that as well. So we think this makes a lot of sense to be tested in humans, and we are moving in that direction already. Now, one of the most exciting aspects of that study is that it seemed to modify the disease. So we stopped the treatment, waited for several weeks, and then we looked at those animals if that benefit was maintained, and it was maintained. That means that these animals, the treatment for 2 weeks with this therapy actually changed the natural history of the disease. And that's one of the very few examples, very, very few examples in the literature of pulmonary hypertension where you have a disease-modifying intervention. now it works in animals, but does it work in humans? We did a randomized, pre-registered, randomized controlled trial in 70 humans. These were healthy humans, not humans with a disease, because we wanted to see, first of all, is it safe? And second, do we have any evidence for suppression of inflammation? And we found that even though these people have very low levels of inflammation, they were relatively young, about 25 to 30 years old, mostly students from Long Island University. The ultrasound actually reduced those inflammatory markers. And it reduced them in an interesting way. So 1 and 2 hours after inflammation, you see this is the levels of TNF, of tumor necrosis factor, which is an inflammatory cytokine in their blood. At baseline, the sham and the treated group are about the same. 1 hour after the intervention and 2 hours after the intervention, their levels are reduced, and they return back to baseline after 24 hours. So the duration of the effect is about a day long. And there was no evidence of toxicity, so very safe. We're, like I said, we're ongoing translational work in this space. We're looking at effects on other cytokines. TNF is one of the most fast-changing cytokines, so you see an effect soon, but then the effect also kind of fades away very fast. But we're looking at interferon gamma and other pathways in response to ultrasound. And also Alexandra, the PhD student, part of her PhD work is to look for inflammatory markers in people with, in actual patients with pulmonary hypertension, and then eventually select those patients to receive the treatment. Now, I was asked to comment on male versus female. This is actually Alexandra's big interest in her PhD because she's a woman, and she believes in addressing these inequalities in how we approach healthcare in women. So one of the chapters in her PhD is about looking at these mechanisms in male versus female subjects. So as you can see here, it's just an example of the many, like hundreds of figures she has prepared. Is the difference in disease severity between male and female subjects. So female subjects have a lower severity of the disease compared to male subjects. RVSP is much higher in male, which is in orange, compared to female, which is in green. Interestingly, there are differences in the response to ultrasound. So Alexandra found that females that receive the treatment do a lot better in their response to treatment compared to males that receive the treatment. So actually in the female population, which is again the purple, it almost normalizes the RVSP. And RVSP is a really difficult measure of disease activity to change with drugs. So this focused ultrasound treatment actually reduced it to almost normal levels. It also worked in males, but not as well. And we think that's because the immune system in the spleen in females is different than that of males, which is, I guess, a finding that has not been described before. So down to the basic immunology of their inflammatory response, women are different. And I think this is one of the very few examples where investigators actually cared about the sex of the animals. I'm going to tell you now that 95% of papers in the area of pulmonary hypertension and neuromodulation are done in male animals. So we had no idea that there are deep fundamental differences in the way the immune system is organized in females, and likewise the way that the immune system responds to these treatments. So this is one of the reminders to all of us who are involved in clinical and translational research that we should always look at both sexes. This is a picture of my lab. Alexandra is in the middle. She's wearing a red shirt. But there are all of these people. Most of them are MDs or PhDs that work in the lab in these different diseases. Stefanos Zafiropoulos, who was the first author of the study, is not shown here. He just about a year ago started a cardiology residency in Zurich, and he's already a team leader there, so he's organizing his own lab. He's also interested in neuromodulation and electrophysiology. And I wanted to very briefly, for 10 seconds, mention that we have an accelerated PhD program that is specific for physicians. It's 3 years. It offers full scholarship, and it allows people to perform translational research at Feinstein and at Northwood Health. And thank you very much for your attention.
So thank you. I mean, it's very rare that there's a talk where I know absolutely nothing about the area, and I think this was one of these discussions.
I was afraid to say the same.
So yeah, I think it's really interesting. You presented some really interesting data where you talk about earlobe stimulation, you talk about ultrasound stimulation, how can that influence the inflammatory response. Of course, for this to be therapeutically useful, you need possibly drug targets, and I know that there's a lot of neuropeptides such as oxytocin, vasopressin that are thought to act on splanchnic nerves. Has anyone looked at these agents or agonists of these agents and how they may impact on inflammation?
Absolutely. I agree with you. In order for this to become widely used, we need a druggable target, and we're looking into basically developing ways of activating mechanoreceptors. So like PSO1, this is a mechanosensitive channel on neurons and on immune cells that we think we're activating with ultrasound. So we're looking into developing very specific agonists of that receptor to see if we can replicate the effects of focused ultrasound with a drug. And this is a very exciting direction we take in the lab. I'd absolutely agree with you on that.
So I have also one short question, because I am also very not very familiar with this topic and so deeply. But how you show already, you checked it in people with pulmonary hypertension, but they are also at different areas, like for example heart failure or maybe atherosclerotic diseases, which are also interesting for this kind of therapy.
Extremely interesting question, good question, and we're very interested in heart failure with preserved ejection fraction. We already have an animal model that we developed in the lab. Those animals have inflammation, their spleens are different, and I have some, we haven't published that data, and it's a bit early even to present it in a talk, but I can tell you that in some early cohorts we did, focused ultrasound works as well. And we know that we kind of expected it, because first we knew that when you suppress inflammation, these animals do better already. We know that when we activate the liver or ganglia inside the abdomen of these animals, we fix their metabolic profile. So you have one anti-inflammatory action, two an action on the metabolic profile that are combined, and in HFpEF, I think it's a very good idea. We absolutely are working on HFpEF right now. And I think in a year or two we'll have some
for the next year
results.
presentation.
Yeah.
Thank you very much.
And we make sure we use both male and female animals in our studies after these findings.
Okay. Thank you very much.
Thank you very much.
You.
Ah. Say something. Thank you very much for coming. I found it very interesting, and it is. I want to ask you, what is your goal for the future? Let's say you believe that this will be a therapy on top of other therapy focusing on inflammation in all these fields, or?
I see the field going towards what Dr. Mama said. So a small, let's say, number of patients will benefit a lot from these devices. But, performing ultrasound on yourself once a week or even, once every 2 weeks at home or going to a clinic is not very practical. I think what is likely to happen is that there will be drugs that will target these mechanisms that we're now exploring with devices. And over the next, I'm going to say 10 to 20 years, we will see more and more of those drugs. There are already companies that are working on it, one of which is Calliope in New York, that they are developing these drugs for nerves that innervate the gut. So they're looking for ways to treat, through the nervous system, to treat inflammatory diseases of the gut. So that's where I see the field going, especially in cardiovascular disease. It's a huge problem. HFpEF is a huge problem in the US. Pulmonary hypertension is an important disease. It's a complex, interesting disease, but it's a rare disease. HFpEF is a huge disease health burden in the US and worldwide.
Thank you very much.
Yes, thank you very much.
Thank you,
Thanks.
guys.
And now I have a great pleasure to introduce my friend Marta Bande. She's coming to us to showing us how can you change your career and build your career, moving from the interventional cardiology practitioners to industry. So I'm really exciting. What can you explain us how to do it, how to be in the same place like you?
Well, thank you very much. First of all, I would like to thank Carmen and Professor Wolfenikis for the kind invitation. It's always an honor to be here, a huge pleasure. And thank you, Marta, but really I have nothing to teach to anyone. But thank you very much, Carmen, for inviting me to share my experience with all of you. I would have actually to make a declaration of conflict of interest in the country, in the sense that everything that I will say today is just my own experience, has nothing to do with my current employer. And I would just like to share with you what this journey has been, especially because I realized that even on the other side, I'm still the only woman. And so I would like to open this up to other women because it's a fantastic opportunity that I've had. And again, nothing to teach, but just a sharing with you of what I've learned along the way. So starting from the beginning, I was born in Sardinia. So I have origins that are very close to my beloved Greece. We share the Mediterranean Sea and a lot of good things. Like great food, great people, and the fantastic color of the sea. I followed into my father's footsteps. He's an interventional cardiologist. Now he currently practices, although he retired as an interventional cardiologist, as a general cardiologist. And he's been kind enough also to support me in this crazy journey that I've been through. And my first love has really been interventional cardiology. Some people have said, oh, well, it's because it's your dad. I remember, yes, from my dad, I was able to see from the very early years that what the lifestyle of an interventional cardiologist looked like, and I really loved it. Everybody would hate a 3 o'clock call in the middle of the night, but we received those at home when mobile phones were not available yet. And I thought, oh my gosh, how nice it is that he gets to go to the hospital and save a life. And I thought it was exciting. And I never stopped to have that spirit because I really believe that interventional cardiology gives you, and cardiology in general, really the fantastic opportunity to really make a difference in people's lives. And so I proceeded with my dream, and I had the great opportunity to train first in Paris with Marie-Claude Maurice and her team. And it's been an incredible year. And then I moved on to train with Professor Colombo in Milano. And I spent 1 year with him and his team. And it's been another fantastic experience that gave me a lot. And then I decided to stay in Milano and practice there. I practiced for 12 years. I had the opportunity to perform coronary therapies, interventions, and structural heart and peripheral, so a broad range of procedures with those two that I call my work husbands, Massimo and Francesco, who've been my partners in crime for those 12 crazy years. For many years, it was just the three of us, so it was quite tough to cover the full calls, just the three of us, but we made it through, and it's been a fantastic experience. And in parallel, my passion has always been the advocacy for other women cardiologists. I've always felt that it was important to have a community, to build a community around us not to feel isolated, because I felt isolated for many years and I thought it was just me and that the problem was me. And finding other women physicians who were facing my same challenges really made a huge difference and had an incredible impact in my day-to-day life. That's why I really believe in women advocacy for cardiologists and women leaders. And then in February 2022, after 12 years of practice, I had the opportunity to join Boston Scientific in the medical affairs team in the EMEA, so Europe, Middle East, Africa, in coronary therapies. I was leading the team specifically for the coronary therapies franchise. This was the extended team with also the structural heart and Watchman. And it's been 3 incredible years where I've experienced incredible growth and unimaginable experiences. And then last March, I started my new role as Associate Medical Director for Interventional Cardiology Therapies in the global team, and I will be relocating to the US in the summer. So now I'm working remotely from Italy, but I've already started in this new role, and it's a new challenge. So I found myself in these past few years in front of significant crossroads, and I will admit I struggled. It hasn't been easy, and it's not easy. I've had a huge identity crisis, and I recognize myself in this excerpt from this beautiful novel from Sylvia Plath, The Bell Jar, where yes, I saw all these opportunities, and it's like, okay, which one I grab? Because if I grab this one, then I will lose that one. And how do I move forward? And so it is not an easy journey. You're a physician, first and foremost. You have spent so much time building your skills and building your community and building your experience and your relationships with your patients, and the fear of losing what you're leaving behind is paralyzing. But then, as this excerpt says, if you don't decide, then all these opportunities are just going to fade away. And so I decided to grab them, and I decided to give it a try. And again, it's not easy, it hasn't been easy, and I share openly my struggles, my full identity crisis, because that's what we all go through. But again, then it's the experience of growth and the experience of moving forward. And just like, in Europe, we know that women cardiologists face objective hurdles. We are underrepresented. The data are clear, especially in interventional cardiology. And the main reason we are underrepresented and we don't take this road of an incredible, beautiful journey of interventional cardiology is the lack of opportunities. And I faced that myself. We know now that the perception is not the same from our male colleagues, and that makes a difference. So we're not scared by high workload, by calls at night, by competition, radiation exposure, but we are scared by the lack of advancement, and that is what sparked, honestly, my will to explore something else, because I felt I had still so much to give, and I was dedicated to my work, but that I somehow couldn't move forward. I said, I just asked myself, is that it? Is there anywhere I can contribute in a different way? And again, these are just the data that we've seen again and again. The lack of opportunities spans from the structural heart interventions realm, where we're very underrepresented, to our presence in editorial boards and in clinical trials leadership, although now we're significantly trying to change that. and of course the leadership positions. That's a huge problem. We are in the field now, and we're getting more and more into the field, but then we cannot move forward. We're stuck there in the trenches. Mamas has done an incredible job in highlighting this perfectly. He's been on point in describing this phenomenon. And this paper, I think, has served our community more than we could have possibly imagined, because this is the harsh truth. If we just look at the numbers, women leaders are not many, and there are even fewer in the interventional cardiology realm. I'm really ashamed to see that Italy, my own country, is very low in this list. And then we lack role models. You can't be what you can see. When I was growing up, when I was studying medicine, I knew already that I was interested in interventional cardiology because of my dad. I struggled in finding a woman role model. At that time, I only knew the name of Cindy Grimes because of the books that my dad brought from the US. And then I heard the name of Roxana Meran, and then the name of Marie-Claude. And then I met Alaide in my early 30s, but again, these were spare images. And most of all, when I had the pleasure to meet Cindy Grimes, it was fantastic, but well, she's tall, blonde, a completely different body type from me. It got better when I met Marie-Claude. I said, okay, now we can start talking. But it's true. It's like you wonder. It's like, you're the short lady, and the table really was too high for me. And you wonder, how do I get over this? How are other people perceiving me? Because, when I see the pictures of me at the table, it's like, oh my gosh, I was really tiny. And I had, I used to call myself, when I wore the sterile scrub, and the nurses were tightening the gown. They were like, oh, you have, the train. I'm like, oh yes, I'm a princess. But then really, more than once, I risked to trip in the middle of the case, when turning around. It's like, it's just, it's not made for us. So lack of role models is an incredibly huge problem, and thank God today we're overcoming that. So you can find the tall one, the short one. When Mirvat shared with me that she wore 5.5 size of gloves, I'm like, oh, thank God, I'm not the only one with the tiny hands. But those tiny hands can do great things. And why would I have to have a huge glove then really slows down my work and doesn't allow me to really feel the guide wire and all the devices that I'm using? We have the right to have our own sizes. So if it's an extra small and it needs to be an extra small, give it to us. If it's a 5.5 rather than a 6, I met a lot of resistance when I asked to order 5.5 gloves. They said, well, can't you just use the 6? And I'm like, no, because I tried the 5.5 and I want that because that is what really fits me. Why do I have to be Cinderella and, not have, or why do I not have to be Cinderella? I want my perfectly fitting glove, just like the shoe. So unfortunately, on the other side, it's not very different. There is this phenomenon that has been described by McKinsey of the broken rung for women in leadership. So women enter the workforce in corporate at entry level. So just like us, they are taking up the space in the trenches. But then it is very hard to be promoted at manager positions. And then it gets okay when you're going from senior manager to director level. But then again, there is a shift when you have to step up to VP positions. So when you're climbing that ladder, unfortunately, there was a figure that I wasn't able to include in this slide, but it's very clear, and you see the man that just climbs up, because he has all the steps ahead of him. And then the woman just finds a broken rung, and it's like, okay, how do I proceed? So it's also this, it's not evident all the time, but then if we don't take proactive actions to change this, then it's still going to be the same for the next 40 years. And we see visibility. It is something that I learned in corporate. Visibility is key. Here we see how it is distributed as conference speakers by industry, and healthcare and hospitals are not different from other industry. So women are not visible. We're doing the work, but we don't have the visibility, and so nobody knows us, and we don't appear. We're just invisible, and so who is going to notice us? No one. And again, I didn't think about this before my experience in corporate, and then I had to experience myself that if you don't have visibility, you can do the greatest work on earth. You can be the most perfect worker and produce fantastic results. Nobody will see them. So this is why we need continuously to fight for ourselves. So again, I have nothing, absolutely nothing to teach you. But what I have learned in my experience on both sides of the barricade in interventional cardiology, so from the hospital and then in corporate, is that hard work always pays off. That's the number one thing. There are no shortcuts. You want to advance, you put in the dedication, you put in the commitment. You stay curious. As physicians, we don't fear hard things. We already did hard things since we were very young, because first we had to get into medical school, then we had to study while our friends were going to the disco, then we had to get into cardiology training, then we had to get into interventional or imaging training or whatever, and then we had to find an attending position and then build from that. And then we've been early career and then mid-career and facing continuously obstacles. We're not afraid of hard. But, and also we're lifelong learners. Naturally, we go to conferences, there are data that are always coming up. We need to be updated continuously. So staying curious is key, and that is one of our superpowers. So hard work and curiosity are really our superpowers as physicians. And then instead, something that I learned when I was exploring, this new hidden world of industry, was the mindset. Somebody suggested this book, and I read it. And while I was reading, I don't know if you're familiar with this concept of growth and fixed mindset, but I was reading it, and I'm like, yeah, of course, I have growth mindset. And I started reading the book, and I'm like, oh my gosh. As physicians, we have such a fixed mindset. But why? Not because we're less than anybody else. It's just that we get risk adverse because our own practice teaches us that we need to be risk averse because we need to protect the patient. We cannot run risks for the excessive risks for the patient. So we need to know when to stop. We need to know when to take risks, but also when to stop. And that affects our whole mindset. So we're afraid to fail. We're afraid of shame. Our culture punishes complications in the cath lab instead of encouraging people to sit down and say, okay, what did go wrong? Can we discuss what went wrong so that next time we don't repeat the same mistake? And litigation, of course, with patients have made that incredibly worse. Everybody's trying to hide their mistakes. Everybody wants the Instagram perfect practice, and oh no, I have zero complication. Well, zero complication is impossible, unfortunately. So this was shocking for me to describe that I had a fixed mindset. And I'm like, oh my gosh, yes, I'm really afraid to fail. And I said, I gotta change that, or I will not go anywhere, because if I want the Instagram perfect picture practice, I will never have that, and it's unattainable, and it's unrealistic, and so how can I change that? And I worked a lot on that. Well, work in progress all the time, and then I learned to ask. I didn't ask. When I was in clinical practice, I kept things for myself, and I complained but didn't ask. I didn't formalize what was wrong and what I thought could be changed. Sometimes I did, but then I received some backlash, and then I stopped. And I realized, no, you need to be afraid to speak up and ask for what you want. And more often than not, you discover that people are really willing to help, and they will listen to you, but you need to voice which are your concerns, which are your requests, because people cannot read your mind. So that I had to learn the hard way. And then keep investing in yourself. You are always your best asset. So I always think it was like that in clinical practice, and it's like that in the corporate part. Every chance that I get to get to any training, public speaking, media training, whatever it is, managing training, I always try to jump at the opportunity, because the more, because then it also translates into a return of investment. The more you build your expertise, it's not that you become irreplaceable. None of us is irreplaceable, but you build your own brand. You do you. And I was so afraid in the beginning to be myself and show myself to the world for what my choices were, and what my choice was to leave clinical practice and try this new avenue. But then I learned, well, I just need to keep moving forward and keep learning. It's a learning process. And each step adds something to your expertise and to who you are. And then I learned not to wait for opportunities to be handed down to me. I tried hard to create them. And that is also how I ended up in industry. I started talking to people, I networked, I asked around, and one thing led to another, and then almost naturally, I got offered this position, and very naturally, I didn't have to look for it. It just came. And kindness always pays off. Keep an open mind, be kind, be generous with your time. Now, when people ask me for help in trying to understand, to navigate, what the change might be, they're interested, they're curious, I always give them my time, because I'm very grateful for those who did it with me, and I couldn't have done this without them. So I always try to pay back and try, again, to share my experience for what it's worth. And another thing that I found that is true on both sides is that really, alone you go fast, together you go far. You need to collaborate with the teams, and teamwork is essential. You can be the best person in the world, the most, the brightest one, and the most knowledgeable one, but without a team, you really don't go anywhere. And I also learned that you can keep your purpose, and you can be passionate about multiple things. I read the other day that finding your passion and purpose, sometimes it's a bit like dating. Some people are lucky enough that they find their true love at 15 and they stay with them their whole life. Some other people need to date a few men before they find the right one. And I found out that, yes, I had an incredible passion for the cath lab and being with the patients, but then I knew also that I was curious for something more, and I gave myself permission to explore that. And I found that I'm as passionate about this job as I was in the cath lab. So it doesn't change. Your passion can be spread among different realities. It doesn't have to be just one. And you are more than your title. You're way more than that. But it took me a long time to get there and to understand that. And then you just have to find your tribe. I think finding your allies, it's essential in any case. Find a community that supports you, and to build trustworthy and solid relationships really helps you navigate the difficult moment and allows you to share the joys in the good ones. So just like the women in cardiology movement, we're really stronger together. And I do believe that women should help other women, not just in words, but with actions. And I try to make that a reality every single day for what I can. Because really, when women thrive, humanity thrives. So to conclude this, I would just leave you with this, that is one of my favorite quotes. Dream big and be disruptive. If you're doing the same thing as everyone else, you've already failed, which doesn't mean that we should all change careers and explore several careers. And it just means sometimes a change in what you're doing. You want to build your clinical practice in a way that other people are not doing. Go ahead, give it a try. It doesn't matter if you fail and if it doesn't work. You've tried. And this is sometimes the most blocking step as a physicians, because we're so afraid of being judged by our own colleagues. Our community has built so much shame around failure that we're really afraid of others people's judgment. What can I say is like, really, there's nothing to lose. You're not gonna die. And I can tell you, because really, I thought I was gonna die by shame when I left clinical practice. It didn't happen. So I'm here talking with you. So thank you very much.
Yes, thank you very much, Marta, for this inspiring lecture and speech. We know each other, and we know that finding somebody around us who can sometimes even not support you personally, but there is a model role person who can you follow and really see that it is possible, that some things can happen if you really dream and you have dreams and you can follow that. So thank you very much for showing us that and summarized it.
No, thank you.
Me also, thank you very much for being here with us. And I was very happy when I saw the concept of the growth mindset. I was thinking how important it is if we can teach young
Yes.
doctors, or even in the educational system, if we can
Yes.
apply, let's say, the growth
Yes.
mindset, how important is that we can change the culture and everything that you said in a positive way.
Absolutely.
Thank you for giving us
thank you.
ideas. Thank you for sharing with us all your experience.
No, thank you.
I know you very well, and you are doing a great job for all of us. And thank you very much for being here.
No, thank you. Really, it's again, it's an honor being here. And just about the growth mindset, we just need to create a safe space for everyone to be vulnerable. We don't have to hide our grief when we lose a patient and move to the next one like nothing has happened. We really need to do a better job at that with us as a community of physicians, with the younger generation, most importantly. And I think that was a big learning. We all play a part in this, and we have the responsibility to change the current culture.
I really enjoyed your talk, although I came a little late.
Thank you.
And I really think that one message that applies to everyone, regardless women, men, is, and also, actually, I think which is the most important thing that leads to burnout we discussing yesterday. If you're doing what everybody else is doing, you will get burnout through the years.
Yes.
And I like the way you see things. And I'm sure that, this is going to be a big motivation wherever you go and whatever you do to other people also.
No, thank you very much. And again, thank you for having me here. I didn't get to this point easily. It's been a journey, and I had to work a lot on myself because I was the first one being very fearful of failure, judgment, shame. And again, I didn't die. I'm still here. So, taking that step allowed me to gain confidence to take another step and another step and another step, and really feel the freedom of making my own choices. So you're going to disappoint some people in a way or another, and it's okay. You can be liked by everyone, but I define myself a recovering people pleaser, so I do know what it means to want to keep everybody happy and to be there in the cath lab for the patients, for the colleagues, for everyone, and saying, yes, not a problem, I'll cancel my dinner 1, 2, 3 times whenever they ask you to cover and yet another shift. We need to do better. We need to do better as a community to support ourselves, among us, and again, most importantly for the younger generations. Otherwise, as we were discussing yesterday, the younger generations are not taking this anymore. So thank you very much once again.
So Marta, quick
Yes.
one final
Oh, yes.
question.
Yes.
I mean, I mean, it's a great talk, and you're one of the people that certainly walks the walk, as we say in the UK. I mean, you've contributed huge amounts to educational content and opportunity for women in Europe, and I'm sure you're going to do the same in the US in your new role. We know about glass ceilings, we know about barriers to women historically. Where do you see them now? I mean, we're talking about these things in the community for the last 5-10 years.
Right.
Where do you see the remaining ones at this moment in time, and what can people like you do to change them?
Yeah, thanks, Mamas. I think there's so much to do still. Okay. The worst thing that I've experienced moving to corporate, one of my priorities was that I could continue my women in cardiology advocacy. And I've done it from the other side because I promised to myself that I would always do whatever was in my power to support other women. And if being in industry meant having more power, well, let's use it. And I had just attended a Women in Cardiology Advisory Board before I joined the industry, so when I hadn't signed yet. And I said, oh, thank God something is moving. So I actually missed from the other side what is happening all these years. And that is very helpful, I think, for women. And again, there is at least effort, active effort, and conscious effort to do something every day. Unfortunately, we're very far behind because I've heard a lot of comments like, oh my gosh, of course she's there giving the talk. It's this women in cardiology thing. I was heartbroken a couple of weeks ago when I invited a person I really admire a lot to give a talk for us. And she said, sorry, I can't accept because they are blaming me of taking advantage now of this women in cardiology bandwagon and being there on podium just because I'm I was like, oh my gosh, we're so behind still. Actually, in some aspects, it made things worse, but we know it's like, the disease. It has to get worse before it gets better. So I'm trusting the process that, keeping on pushing and giving the antibiotics to this bad virus will bring us to full recover. And one day we will not have to say a woman interventional cardiologist, a woman medical director, a woman whatever.
Thank you.
Thank you.
Yes, we should finish the session now. We are a little bit over time, but please stay with us, and we are moving to the next session about structural diseases.